करतो मग करा.
ओके सर.
कुलकर्णी सर.
बोला
सर चालू करतो. मी तुम्हाला थोडं मग हे करतो इन्व्हाइट. 2 मिनिटात चालू करतो. शीतल.
सर am I audible now? हाँ सर.
कुठून तरी इको येतोय.
Yes, Sarita ma'am, you are audible now.
हा सरिता मॅम आता दुसरं लॉग ऑफ करा, दुसरं कनेक्शन.
Yes.
Sarita ma'am, are you तुम्ही इंट्रोडक्शन द्याल का की मी देऊ?
You go ahead, Parag. You go ahead.
We are already live.
Okay.
Yeah.
Okay.
डीजी शील्ड कोण आहे तो होस्ट? चालू करू?
Yes, sir. We can just a moment. We can start, sir.
Okay. Welcome all on behalf of IAP Pune. We are starting this webinar on in the pediatric hematology. We'll discuss about recent advances and management about thalassemia today. We have renowned hematologists from the Pune city, Dr. Parag Mahankar and Dr. Sarita Verma. Both are pediatric hematologists, will moderate the session. And we will have panelists as Dr. Shailesh Kanvinde, Dr. Lisa Balsara, Dr. Bartakke sir, and Dr. Vibha Wafna ma'am. So I request Dr. Pramod Kulkarni sir to give opening remarks.
Good afternoon, everybody. Welcome here on behalf of Pune IAP and Central IAP as well. And this is a golden opportunity to hear about a disease, hematological disease, since olden days, so common to us and cared by all these stalwarts hematologists from Pune. So we are going to listen to the recent advances and the developments in the field of thalassemia handled by all these experts. And let us go ahead and learn from these leading hematologists and what is the current science and what are the current practices. Thank you very much. Please guide us.
Yeah, thank you, sir. I now hand over to Dr. Parag Mahankar and Dr. Sarita Verma, ma'am. Over to you, sir.
Good afternoon, everyone, and warm welcome to the panel discussion on the thalassemia update. I'd like to thank Dr. Parag Gaikwad sir for giving us an opportunity to moderate this session with the eminent oncologist from the Pune city. So for a pediatric thalassemia update, we are going to here. So the panelists for the today's discussions are a very well-known pediatric hemato-oncologist from Pune city, Dr. Vibha Wafna ma'am, a consultant pediatric hemato-oncologist at Bharti Hospital and Jahangir Hospital, Dr. Sandeep Bartakke sir, a consultant pediatric hemato-oncologist at Surya Hospital Pune, Jupiter Hospital, and Aditya Birla Hospital. Shailesh Kanvinde sir, consultant at Dinanath Mangeshkar Hospital, and Dr. Lisa Balsara, consultant pediatric hemato-oncologist at Jupiter Hospital Pune, Inlax Budrani Hospital, Rudir, the Lifeline Thalassemia Daycare Center in the Pune. So without wasting any time, let's start the discussion on thalassemia. So we'll go ahead with the case scenario. So here is a 1 year, 2-month-old Ashray. He is admitted in the pediatric ward with acute bronchiolitis. On clinical examination, child had a pallor and there is a firm hepatosplenomegaly. So on the routine evaluation, the CBC was done, which shows a hemoglobin of 6 gram per dl and RBC count of 2.33 millions. There was a microcytic hypochromic pictures, platelet and WBC count was normal. So in this age group, we know it's a iron deficiency anemia is common. So we did a serum ferritin, which was like in the normal range. The peripheral smear shows microcytic hypochromic anemia. There was an anisopoikilocytosis. There were polychromatic cells present, and there were pencil cells, target cells. And the smear also shows 4 nucleated RBCs per 100 WBCs. So when we go for an HPLC report, we found that the HB electrophoresis report was non-conclusive. It shows a hemoglobin A of 65%, hemoglobin A2 of 3.2%, and a fetal hemoglobin of 26%. So we again inquired with the parents. So they told us that child has received 2 pre-CV transfusion in last 3 months, and the last transfusion was given around 5 weeks back. So this is a common situations we come across in our day-to-day practice, particularly in the institutional settings. So I like to ask Dr. Lisa, which are the indicators in the CBC which points toward the thalassemia diagnosis in this patient?
Thank you, Dr. Parag, for the question. And this is a very typical scenario in almost every case. So HB of normal value for the age and the sex of the baby, and MC being going towards a cytosis, and RDW being high, which is all the pointers. Because I think that this is the point we have to think about hemoglobin. But obviously, we for a giving us the clues every present polychromatic and 4 RBCs being present in this. Since the HPL is not of anything when you, and in that case, serum ferritin being normal is completely ruled out. And as far as the ferritin level, so inquiring regarding the transfusion is a very good indicative that the HPLC is conclusive, and obviously not. Hello, am I audible?
Your voice is breaking, Lisa.
Is it okay now?
Hello, can you go ahead? Yeah, it is okay.
Yeah.
Now. Please go ahead.
So MCV being lesser and RDW being higher is a pointer towards a hemoglobinopathy, and peripheral smear being polychromatic and nucleated RBCs present and target cell presence in peripheral smear is also conclusive towards a hemoglobinopathy. Doing an HPLC was a right move to be done, but when it is non-conclusive and non-reliable with the history of transfusion, then we will have to go ahead with the confirmatory test.
I like to ask, how will you confirm the diagnosis of thalassemia in such situations?
When it becomes very tricky situation when the child has transfused multiple times before coming to the setup, and in that scenario I will like to do a genetic test, and a genetic test which will include a molecular sanguine sequencing and a reverse dot plot test and everything, which can give a confirmatory test of a beta thalassemia homozygous or an HBD beta thal, and sometimes an HBS sickle thal also is present like this.
Okay. So I like to ask you, is it necessary to do a genetic testing in every patient with thalassemia?
No, it is not necessary. Sometimes when you have a de novo case and the child has walked into OPD not regularly transfused, and before transfusion, if we have done an HPLC and HPLC is reliable and confirmatory, in all the cases we do not do it. But in most of the scenarios for OPD, the child is already multiple transfusion or it is already on a regular transfusion regimen. In that case, HPLC is not reliable. Sometimes the HPLC and the blood test is not equivalent to whatever clinical complaints he is presenting. And the first child, if it is thalassemic and the parents are planning for a second child, in that case, the prenatal diagnosis, or we know that there is a thalassemia history in the family, and then we do an HPLC for a prenatal diagnosis, then it is necessary. And sometimes congenital dyserythropoietic anemia or bone marrow failure syndrome come in the certain age group, and then we are really confused what to do. In that cases, genetic test becomes mandatory.
Okay. Thank you, Lisa. Thank you so much.
Lisa, I have one doubt.
Yes.
Can we do the screening of both the parents in this above situation
Hmm.
by HPLC? And
Yes.
if both of them are thalassemia trait,
Yes.
can, I mean, suppose cost-wise, how effective and how practical solution is that?
Madam, for every case, be it sickle, be it thalassemia, we are doing parents HPLC as a confirmatory marker. That is the must. But we are doing a genetic test when they are planning for a second baby. And the another thing, we actually encourage them to have a second child for the social reason and also as a cure for this child, so we can take ahead for bone marrow transplant. In such scenarios, we want the genetic test so we can further guide them.
Okay. So for the index patient, mostly you want to
Yes.
get a genetic confirmation on this. Thank you
Yes.
so much, Lisa.
Welcome.
I am putting my question to Dr. Sandeep Bardakke, sir. So because the discussion is going towards all the genetic testing, I would request you to shed some light about the sample required for genetic testing and whether it has to be at a specific timing in relation to the PCV transfusion. Sandeep Bardakke, sir, hello. Can I redirect my question to Dr. Shailesh Kalvinde, sir, then? If
Okay, so the question was, when can you do the testing, right?
yes, sir. Is it like HPLC? Does that genetic testing also the reliability decreases if it's mistimed as per the relation to the blood transfusion?
Generally not, but most labs would say do it after a week after a transfusion. But and doing it by maybe I do a simple blood sample collection. So a week after last transfusion probably would be a prudent idea, though I don't think it will interfere too much with the estimation.
Yes, thank
So
you, sir.
practically, like you
And
can time it when the patient comes for transfusion.
pre-transfusion,
Yeah,
yeah. Practically,
pre-transfusion
we
is the
all
best
do
time.
that.
Whenever we are going to
But you can do it after.
that is the best time to do the investigation. Yeah.
Yes. Should we send for all the mutations or only the most common 5 mutations which are prevalent in our country?
Initially, we do screen for the most common ones. If we don't find anything in that, or if it is inconsistent, then we go for a wider screen. And but I think as a routine practice, screening for 5 mutations would be the standard approach.
Practical and cost effective as well. I mean, most of the times 95% of our population gets picked up by that. Only rarely we need to do, I think, the complete beta globin gene. And so if the genetic test is negative, suppose the mutational analysis is known, whatever is there, all that is negative, does it totally rule out thalassemia?
I think we would, after doing all the Sanger and everything you're saying.
Yes, sir.
Then it will be difficult for us to say whether, I mean, it's there could be unknown mutations also, no? But that's chance of that is going to be very, very low. So I think practically we would say that we would not be labeling it as thalassemia.
Don't
we would
consider
look
it,
at other conditions which are similar, such as CDA and other hemoglobin disorders.
Yes, sir. Thank you so much, Shailesh Kalvinde, sir. I would like Parag to take over for the next questions.
Yes, sir. So, my next question is for Dr. Vibha Bafna, ma'am. So, ma'am, now these situations are common in practically in the hospitals. We get a many frequent scenarios like this. So, I would like to ask you, what should be an ideal approach to the child in such situations to avoid further testing, like testing and spending a lot of money in doing this test?
I think at this point of time, this question is really perfect. So there could be very simple dictums that we could follow. So if you have an infant who has more than mild, moderate to severe anemia for the first time, and there is microcytosis on the CBC, or even if you could just suggest an anemia, at least before you decide for a transfusion, we should ask for a Hplc in our country. Since our country has a very high load of thalassemia, like 3% of our entire population on an average are carriers, and at least more than 1% of our couples are at the risk of having a thalassemia major baby. So I think this is a common indication. There should be a great awareness amongst pediatricians, general practitioners, and whoever is managing these children. And we should be asking for a HPLC. Just a very simple dictum. Hemoglobin less than whatever 8, 7, do an HPLC. And if you take it further, so if you have a classical clinical scenario, just as a child you presented a firm hepatosplenomegaly, microcytosis, very wide RDW, and nucleated RBCs on a peripheral smear, this would be absolutely a red flag. I could also say that, avoid transfusions. If you're thinking there's microcytosis and the child is just mildly anemic or moderately anemic, avoid transfusions. And if you cannot avoid a transfusion, at least send for an HPLC before you transfuse. And these samples stay. You just have to take an EDTA sample and you can save it in the lab. I mean, for the later date, it can be stored in the lab for future analysis.
Yes, ma'am. These are the two take-home messages, like avoid the transfusion prior to confirmation of diagnosis. And if you have an emergency situations, then just store the sample or get the HPLC done prior transfusion in the child.
Just these very simple things will avoid so much confusion. We discussed prior mutations, common 5, 20 to 200. So all this will be avoided. It will be clear-cut whether the child has thalassemia, because that will be a phenotypical diagnosis better than a genotype diagnosis.
Correct, ma'am. So, ma'am, during this age group, this nutritional anemias, particularly iron deficiency anemias, are also common. So, is there any impact of this iron deficiency state or a nutritional deficiency anemia on the HPLC report?
Not in the case of thalassemia major. Okay, but this is a very apt question when you are doing an HPLC to screen for thalassemia minor. So if you have a child with thalassemia minor, you diagnose it when, if the HbA2 is more than 3.5. But if this patient also has a concurrent thalassemia, iron deficiency, then your A2 may be less, and that will be a false thing. So you would have missed the diagnosis of thalassemia minor. Now this becomes a very, very important question, especially in the antenatal scenario or in the antenatal clinic scenario. So you have to know about this. The best way to screen in this situation, in the antenatal situation, but would be just to do an HPLC, because now the costs are really coming down. And in the antenatal period, there isn't much time, so that you correct the iron deficiency and then you do the HPLC. So this is practically not feasible. So I would very strongly put in a case for doing an HPLC for each and every pregnant female who comes at about, who registers early in the first times.
Thank you so much, ma'am. I'd like Dr. Sarita to take over further.
Yes, sir. So I would like to know from Shailesh Kalvinde, sir, when for the first time, we reveal the diagnosis of thalassemia, transfusion dependent thalassemia, if we are looking towards, parents have got so many questions. Like they want to know right from the management to future to prognosis, everything. So like, let's say the parents for the first time, like this index patient, which we have discussed, the parents want to know how are we going to manage his condition.
Dr. Parag, Bharatakke sir joined.
Okay, thank you, sir.
Yes, sir. So Shailesh Kalvinde, sir, we wanted to know what all we should tell to the parents of this child when they want to know how are we going to manage this child's condition.
So what we usually do at the first meeting of whenever we see and diagnose a patient with thalassemia is to give them a broad overview of what we are going to do or what is necessary in the treatment of thalassemia. We start off with advising them about the transfusion therapy, how it is to be done, then what would be the side effects of those therapies, what will be the long-term outcome that we can expect with transfusion therapy. At the same time, we would advise them about what are the definitive treatments available, like a bone marrow transplant, which can be offered to the child. Third thing that we also use this opportunity is to stress that, well, one child has been born in the family, then another child is not going to be born in the family. And this is the first time that we stress the need for prenatal diagnosis during the next pregnancy. We not only tell them that, we tell them that to advise their own siblings, siblings of the parents, to undergo the testing so that at least some form of prevention can be done. So these are few of the basic things that we would discuss with them at the first instance.
Yes, sir. I would like to ask Sandeep Bhattakke, sir. Sir, when they ask the parents, when they for the first time ask details about what type of blood transfusion or how long the blood details should be disclosed to the parents, what like sir said, no first meeting opportunity, what all regarding the blood transfusion information we should give, especially our population, many of them will be quite skeptical about the blood transfusion. So is there some filter, I mean, how much to tell which we want from them, compliance wise also?
Okay, so obviously first thing, as you rightly said, in the first meeting, if we tell them lots of things, then they they may not absorb all the things. So you have to assess their education level, their understanding level, and accordingly tell them. Obviously, we need to tell them that this is the disease where they are going to require management for long time until a curative option is exercised every 4 weekly, 3 weekly, depending on the child's condition for his growth. Well, importantly, because most of these children will be diagnosed in infancy. So, and this is the time that they will grow. So for his regular growth, we need to transfuse regularly. That has to be impressed upon them. Maybe the details may be avoided. We try not to scare them that later on they will have iron overload. That can be discussed later. It's not necessary to discuss right in the first meeting, but it's important to tell them that the child needs blood transfusion regularly for his growth, and of course that has implications which will be discussed in subsequent meetings.
Yes, sir. So I
would
think,
say that it is good to keep a positive outlook. I mean, our body language and our language should be always towards positive, because, and it is rightly so, because so many new therapies, so many new things are on the horizon.
Correct.
Yes. So I think the word of wisdom from our teachers is key, that first meeting opportunity should be directed towards positivity, saying key, yes, the supportive treatment is positive, and taking that opportunity in short, I mean, not too much of information theoretically, specifically when we see our residents, talking to them, right? Taking that, all the book knowledge and talking to them. So yes, thank you so much, Bhattakke sir and Vibha ma'am. I wanted to ask Shailesh Kalvinde sir, one tricky question most of the parents ask us in the first meeting itself, saying, what is going to be the life expectancy of my child on just conventional or a supportive treatment that you are telling me? So how do we address this question?
So at the outset, when we discuss the transfusion along with the need for ion chelation, because like we see so many patients who come to us at 10 and 12 years of age who've just received transfusion and never been advised chelation at all. Okay, so whenever we talk about what is going to be the outcome of these children, we talk about how, if they are optimally managed and if they are not optimally managed. So we give them an idea that if ion chelation is not done properly or not done at all, and only transfusion is undertaken, then the survival of these children is not going to be very good. But if you do regular transfusions and take optimum chelation, then survival even in the fourth, the fifth, and sixth decades is possible with just transfusion support and ion chelation alone. So that is one sort of a benchmark that we establish as far as what is the outcome which is going to happen if these two practices are followed diligently. So definitely it is not though it's more of a palliative kind of, it's not a curative treatment, but still the outcome with this treatment can be really, really good if done meticulously.
And including very good quality of life, I mean, in their educational fields, in academic fields, in performing, having children, having proper fertility. So to that extent, patients have been managed.
So I take this opportunity to ask all three of my mentors. I mean, I have been like a student to all three of you, sir. So Vibha ma'am, Shailesh Karvinde sir, and Bhartakke sir, I want to know who's the eldest, most well-managed thalassemics in your cohort so far. I mean, I want to know the upper age limit. You would say you have had, let's say what, 45-year-old doing well and something like that. Some encouragement to us. I mean, we budding caretakers, ma'am.
Shailesh, you go first.
When I was in INLAX about 10-15 years ago, we had about 30-35-year-old patients. So they must be now in their 40s and 50s now. And they are doing pretty well. In Dinanath, I think the oldest will still be less than 20.
Yeah.
Because
Bharti Parag knows him. So we have a child who is now 21-year-old.
21 years. Yes, ma'am. It's a 21-year-old.
Engineering in Apna, and he's gotten through his own muscle, extremely intelligent. And if you look at him, if you see him, he's absolutely fair, normal looking, normal height. Absolutely, everything is normal. And the child is battling not just with thalassemia and chelation, but he's also seropositive. So considering that, he is really very good.
So that's really encouraging for us so that we can quote them. Even we have had some.
I just want to take a little thing from Shailesh sir because he was in INLAX and currently I am there. So I think his patient only, what we have is a 48-year-old, regularly transfused every 28 days. She is a CEO of her own company, a mother of 2 children, and she is a model for baby products as a mother and child. So I think, sir, your patients are doing that well currently, sir.
So yeah, I'll request Dr. Parag to come on track and let's move ahead. I mean, this thing is, we can just stay in awe of all those experiences, right? Yes,
thank
Dr.
you,
Parag,
Dr. Sarita. Yeah, thank you. So now, Lisa, just you said that in INLAX there is a patient now. He's a 48-year-old. So not moving to the adults, but just like in properly managed, these children are growing very well. So when they enters the adolescence age, maybe crossing the weight of 35 kg, 40 kg, then how to transfuse these kids? Means, is there any upper limit to transfuse a volume of blood at a one time, practically?
So the basic rule, what we all follow is to keep and maintain the HB, the pre-transfusion HB more than 9.5 pre-transfusion. And for that, we give around 15 to 20 ml per kg blood, which is fresh, leukodepleted, net tested, and, gone through the all processing. So usually with what we prefer and whatever daycares we have been, the policy is that we comfortably give around 2 units. There are certain daycare which in adult practices like AIMS, Delhi, and they have a night daycare where they give 3 units during the night transfusion, but that is in adults. So in adolescent, we are still practicing 2 units to maintain their cycle around 20 to 21 days and maintaining the pre-transfusion HbS 9.5. That is the practice we are going. I am not very comfortable with 3 units yet in an adolescent age group. Adults, definitely, yes, probably they are doing 3 units also. And I usually transfuse them in a day 2 units around the same daycare facilities during their visit and try to maintain a very profuse long cycle of 20 to 21 days and maintaining pre-transfusion HB. But if there are like very the massive splenomegaly or patient is having recurrent infection not able to maintain the HB, and HB is drastically falling post transfusion also, in that case we take the schedule of shorter transfusion period. But if the patient is maintaining HB of 9.5, we have a regular transfusion period with the HB, pre-transfusion HB maintained at 9.5 with 15 to 20 ml per kg during one visit.
If in any case, if the child requires more than 2 bags, maybe say 3 units of PCV at one time, is it good to give a one half of the transfusion today and half of the transfusion on next day, or we should give a complete transfusion at a one time and maybe shorten the duration of follow-up? Which will be the better practice to do?
The better practice is to shorten the duration of transfusion. Do not, it is a mental thing also with the child to come to daycare every time, get pricked, send samples. In that cases, to maintain the HB and everything else, we will have a shorter transfusion period for a certain transfusion. And once the patient starts maintaining the HB, in that case, we can go to the normal or regular cycles.
So giving in blood in aliquot will not be a good practice. It's better to shorten the duration of follow-up.
So basically, in that thing also, getting an aliquot also in our scenario is a little difficult thing. Requesting 2 days. So we will have to be practically feasible option also has to be provided.
Two bags can be given in one day.
Yes,
you have a child weighing 40 kilos, you can give him 2 bags of transfusion over those 4 hours.
Yes.
So actually, that was my next question to Dr. Lisa. That if like we need to give it 2 bags, so over how many period or time we should finish that 2 bags? Like we should give like every bag, one bag over 4 hours and another bag over 4 hours, or entire transfusion can be finished over the 4 hours period.
So basically what we do is we do not follow any dictums of 2 hours or 3 hours. We basically see if the child is comfortable first of all. So we have tried to finish 2 bags in 5 hours because mostly that is the adequate period of time and child is also comfortable without going into any adverse events or something like that. But 1 bag for 4 hours is not quite possible anywhere. 8 hours daycare visit cannot be possible. So we are very comfortable with 5 to 5.5 hours for transfusion of 2 bags.
Yeah, that will.
If I may add one thing,
yes,
it does not matter whether it is 1 bag or 2 bags.
Yes.
Depends on what is the per kg dose that you are giving.
Correct. Yeah.
And the volume infused. The recommendation is to give 5 cc per kg per hour.
Correct.
So if it is a 60 kg child, then you could finish 1 bag in an hour.
Yes.
Maybe it's after the initial 15 minutes or so, you could increase the rate. So it doesn't matter how many bags are there. It is what is the total volume that you are giving. You need to be careful if there is an underlying cardiac dysfunction or if there is severe anemia. The child has come after 2 months or 3 months and hemoglobin is 3. There you better be careful how you are infusing, and then maybe you could prolong the infusion at least over the first bag. But for those who are regularly transfused, maintaining a good hemoglobin, you just go ahead and give it at 5 cc per kg per hour.
The other thing that we need to remember is that once the bag comes out of the bag, it should be finished within 4 hours. You cannot leave the bag waiting, for 6-7 hours. Sometimes I've seen one single transfusion going on for 6-7 hours. It has happened.
So Shailesh sir, just now you mentioned that if the child is well, not having any cardiac issue, we can transfuse that 15 to 20 ml per kg volume over 3 to 4 hours. So if in any case, if the patient is doing follow-up after 1.5 months or 2 months, and now the hemoglobin is say around 4.5 or 5, then in these situations, we should do a small aliquot blood, maybe some on today, some on the next day, or we will go ahead with
the initial transfusion. When you start the transfusion, you probably need to start it at a slower rate instead of the 5 cc per kg. Maybe after an hour or 2, you could then gradually increase the rate and see how the child is tolerated. So for those children with severe anemia, you may have to take a call on an individual basis. But I think it's best to finish the transfusion in the same setting.
So they will have to stay overnight. So we will have to give, raise by 3 or 4 on one day, and the next day probably go up to 12.
Okay. So in the exceptional situations, we can give a blood over the period of 1 or 2 days. If the patient is not doing regular follow-up, there is an issue about the cardiovascular, means maybe a patient may be having in the signs of maybe a cardiac failure or very severe anemia.
Yeah, in that situation, maybe you'll have to use a judicious approach.
Okay.
You may have to use diuretics and.
So how much blood is required depends on the initial hemoglobin. So the desired hemoglobin minus the present hemoglobin, that is the thing. And at one time, you cannot give more than 20, maybe 20 ml per kg. So then if the child requires more than that, then you've got to divide it into 2. So, and it is a good idea to give it today and tomorrow. So that if you don't, you just let them go home today only. So they will go home with 7. Again, after next 15 days, they'll come back to 4. So the cycle will go on, and then the child will end up with a lot of extramedullary hematomas.
See, a practical way is actually to decide what is going to be your transfusion for a particular time. If you realize that the hemoglobin is much lower than what you had anticipated, then planning for a second transfusion, that time is going to take some more time.
Yes.
So what you can do is you can call the patient later on at an earlier date, maybe 1 or 2 weeks earlier for the next transfusion, so that over the next 1 month or so, the hemoglobin has risen to the desired level. Instead of asking the patient, because they have come, they know they're going to come, take transfusion and go. Now, if you ask them to wait and then, okay, one today, one tomorrow, then everything becomes haywire. So, best thing is to have a fixed dose of transfusions at fixed intervals, and you may reduce the gap between the next transfusion if you feel that the present hemoglobin is on the lower side. So give a top-up.
Sir, in the same situation, there is an unexpected fall in the hemoglobin, pre-transfusion hemoglobin, and if we are not anticipating that the hemoglobin will raise to the adequate value with the 20 ml per kg, so is it advisable to recheck the hemoglobin level after transfusion to see what is the post-transfusion hemoglobin? Means like,
if that is happening repeatedly, yes. Otherwise, we usually don't. It's just a one-time incident. Then we probably won't need to do it. But next time also the patient comes, we find that hemoglobin is much lower than anticipated. Then you should document how much has been the rise and then how rapid is the fall.
Okay. In the exceptional situations, we need to check the post-transfusion hemoglobin. Okay. Yeah.
Otherwise, not routinely.
Okay. Thank you so much, sir. Dr. Sarita, can you please take over?
Yes. So taking ahead from here, the blood transfusions, when the children start taking, we come across very commonly, like this child might get a febrile non-hemolytic reaction during his ongoing blood transfusion. This question is addressed to Dr. Sandeep Bartakke, sir. We want to know from you how we can minimize these incidences of acute transfusion associated complications, and little about the controversial concept of giving antihistaminics and steroids during, many centers, in the periphery or somewhere will practice it routinely, that during transfusion orders are there. Lasix, Ivil, Hydrocort, paracetamol already given. So this issue I would like to be addressed by Dr. Sandeep Bartakke, sir.
Okay. So first of all, I would say that this practice of giving Avil, Hydrocort or whatever routinely is not justified, not recommended for any transfusion. And definitely this applies to transfusion for thalassemia children as well. Okay. But sometimes you can come across febrile non-hemolytic reaction. Now, this is mainly because of the leukocytes which are present in the donor blood, okay, and the cytokines which are present in the blood. So, how to minimize this? The best way to minimize this is leukodepletion. Now, leukodepletion nowadays, many modern blood banks do the leukodepletion at pre-storage level. So they before storing the blood, they will be leukodepleted, and there are different degrees of leukodepletion, 2 log, 3 log, 4 log reduction. But more commonly, where this facility is not available, many thalassemic patients are using bedside leukofilter, where at least there is some leukodepletion. So this definitely helps. So this will definitely reduce these febrile reactions. And sometimes, despite using leukodepleted blood or bedside filters, some patients tend to have these reactions repeatedly. In those cases, probably one should look for saline washed RBCs and try and give triple saline washed RBCs. And in those cases, maybe sometimes you are justified giving some pre-medications. Otherwise, no. The best answer to this is leukodepletion.
Yes, sir. Sir, any role of, I mean, in our practical setups, I wanted to know, any role of doing extended blood group phenotyping of all the patients before, I mean, whenever.
Yes. So in an ideal situation, one should go for extended phenotype typing of RBC. Why it is important? Because normally what we check is ABO and RHD antigen. Okay. What extended phenotype means is also knowing the other phenotype which are more immunogenic, like other RH antigens like big C, big E, small e, and KL antigen. Okay. So if we type this before we start transfusion, and if we give matched blood, okay, so phenotypically matched blood, then chances of development of allo antibodies, so antibodies to the donor RBCs are less. Okay, so to avoid or to prevent allo immunization, extended blood group phenotyping helps, definitely helps, and that is recommended. But
So,
again, the problem practically problem that it is not available everywhere. I think that the certain blood banks are still doing it. Okay,
yes, sir.
and yeah, so yes, that's ideal, but unfortunately, that is not universal situation at the moment in our setup.
This has to be done before giving even the first transfusion.
Yes, ma'am. That is
so
what
that
I was about to
is a
insist.
challenge. Yeah.
Absolutely,
Yes,
absolutely, absolutely.
Because
And what you can do nowadays, of course, yes. Now we can not only do this is done by serological testing. Okay, so you have panel of 11 antibodies or whatever extended antibodies, and then you can test it. But now we can do RBC blood group genotyping. Okay, so because that will help in difficult situations where you are not able to detect or type the RBCs phenotypically.
Okay. Sir, my question to you was, I mean, we keep on talking about, no, just to prevent this alloimmunization. Maybe someday in the future, if we are able to do this, that catching hold of the child pre-transfusion diagnosed and ideal scenarios, let's say, is it still practically feasible in our setups to get this fixed group of donors? I mean, your setup or maybe Shailesh Karvindeswar or Vibha Bafna ma'am, have you been able to execute this concept of having fixed group of donors for fixed patients? I mean, dedicated center?
Yes, I have been able to do it once because the family was extremely motivated. So in the first place, they were very worried about transfusions. So then while discussing, I mentioned that, you could have amongst your friend group, not relatives, mind you, it should not be even distant relatives, but a group of friends. So this was a patient who was from a particular community and they had a very huge social network. So they identified about 15 to 20 people, and they would regularly donate. So it came to like one person donating twice in a year for this particular child. And it worked extremely well.
So that should be encouraged by all of us, maybe then.
Because the child would get fresh blood, the donor would donate a day or two prior and the child would take it.
No, actually, there would be an issue with this because at least what we had this discussion with our blood bank long back ago is the issue of directed transfusion. Like previously used to have somebody bring the donor, bleed the donor and transfuse the blood to their desired patient. That practice is no longer encouraged because especially related to the HIV, rules related to HIV disclosure and all that. Because if the patient by any chance has some abnormality in the serology, or the donor has some abnormality in the serology, the blood bank cannot disclose it to anybody. And then they cannot disclose to the parents or the relatives why a particular blood bank which they had brought is not being used for their patient. So that is one reason why directed transfusions is not encouraged in blood banks, unless you have absolute shortage of blood and then you bring somebody and then okay, that thing can be given. But otherwise, they say, so I don't know the current scenario. This has been long back. I mean, this was about 10 years, 15 years ago.
Even this patient I had was long back. So the thing is that there has to be this amount of motivation and they have to, there is no way we can, manage this kind of thing. We can always
Practically, it is very difficult.
It is very difficult, yes.
However, patients who is alloimmunized, there it is important, because then you know
this
you identify
particular donor's
those
blood he tolerates.
matched donors, and there it is becoming more important.
Yes, Sandeep Bhattacke, sir, I'm coming to the same concept now. We encounter this problem quite a many times, when the kids are getting older, that we'll get a phone from blood bank saying, for this patient, we have tested so many bags and are unable to find a compatible blood. So just wanted you to shed light on this situation and how can it be prevented, and if encountered, how to manage it, sir?
Okay. So the blood is not getting cross-matched. That means the indirect Coombs test is positive. What it means is that the child has developed either alloantibody or autoantibody towards the donor blood group. Okay. Now, what are the risk factors? Before we go on to how to manage it, we should know what are the risk factors who are at more risk of alloimmunization, and what is the normal prevalence of alloantibody in our setup. So the risk factors, as we know, if we start transfusion at a later age, so patients with non-transfusion dependent thalassemia especially, that is one. Second, those who are splenectomized, they are at more increased risk of alloimmunization. So it's important to, so we should be more careful in these patients, and then we should do proper workup. So for diagnosing alloimmunization and autoantibody formation is important. So for that, extensive workup should be done by the blood bank, including your DCT, ICT, your testing with the extended panel, and identifying the antibody. That is very crucial, that we need to identify which antibody is causing, so that then we can give appropriate blood. Okay, because otherwise what is going to happen, because whatever blood you give, it is going to get immobilized, and you are going to require more and more blood. So for that, phenotypically matching or extended phenotyping is crucial, and that should be done right from the beginning. But at least those who have alloimmunized, there we should try and do extended phenotyping and giving the match blood, which is difficult, not easy. So you need a lot of support from your blood bank. And another thing, how to treat them. Of course, you can use short courses of steroids here, and even we have used rituximab in a couple of patients with good result.
Okay, sir. Thank you so much. This is one of the tricky situations. I mean, many of us have, I'm sure, encountered and tried to manage in whatever ways possible most of the times. I hand over to Parag to take over the next questions.
Thank you, Dr. Sarita. I'd like to ask Dr. Vibha Bafna ma'am about the chelation. Now we have a lot of discussion about the transfusion. So let's move on to the next topic in the management of thalassemia. So, ma'am, which drug generally you when you start the chelation in these patients, and which is a preferred drug, and at what dosage you starts with this medication?
Actually, when thalassemia was first described, the first life-saving intervention was a blood transfusion. So if you transfuse a child and you don't chelate, his life expectancy is going to be only till the second decade. And cardiac iron accumulation and cardiac failure will be the end event. But chelation has really changed the life of this patient. So you are now expecting an outcome at least till the 5th and the 6th decades. So iron chelation, it's a very, very long topic and very difficult for such a short time. But everybody knows there are 3 drugs which are available. The first drug was the deferrioxamine, that is Desperal. But it is still the gold standard iron chelator. Its main drawback is that it is to be given in a continuous subcutaneous fashion of 20 to 40 mg/kg. The last drug which came out was the Deficiency, and which is one all of us use. we start Deficiency at around 2 years of age, and after 10 to 15 transfusions or if the serum ferritin reaches more than 1,000. And we start at a dose of 20 per kg. We escalate, we monitor it continuously with the ferritin levels, and we may go up to 40 mg per kg. It's an excellent chelator. It should be given only once a day. It should be given empty stomach, dissolved in a non-steel cup, and on an empty stomach. So, yeah. And the other chelator, which is Deficiency, was the second chelator to be discovered. It was oral, so there was lots of enthusiasm when it came out. But it needs to be given 3 times a day at the dose of 75 mg per kg. The biggest plus point about Deficiency is it's an excellent tissue ion chelator. So, as far as chelating iron from heart and the liver, it is one of the best amongst all three. But the drawback is its side effects, especially the hematopoietic side effect. It can cause neutropenia or granulocytosis, which is reversible, but sometimes it can be life-threatening. And another very important side effect is the arthropathy, which can be irreversible. So that is, these side effects has a little bit put Deficiency out of practice. But yes, it is still a drug which is added in combination. So very heavily chelated children, especially who have a bad start cardiac values, Deficiency is added to Deficiency and now also to Hesivax. So this is in short about iron chelation. We also need to look at the side effects. So whichever iron chelator we are giving, we should know what are the side effects. For example, if we are doing Deficiency, we need to monitor the creatinine and we need to monitor the liver function test at regular intervals. So thankfully, they are dose-related side effects. So you just decrease the dose or give a short break, and creatinine and all comes back to normal.
So, ma'am, you explained that Deficiency is much safer as compared to the other two chelators.
Yes,
so anything needs to be monitored while, yeah. So anything do we need to monitor in the children who are receiving the Deficiency?
So if you go by a textbook, many things are there, but in my routine practice, and I'm sure everybody will, we really encountered very less side effects. So what the product information says that we need to monitor creatinine and liver functions once in 3 months. So yeah, and that's about it. And as I said, it is dose dependent. I mean, you just decrease the dose or stop the drug for some time, and the values come back to normal. So they're absolutely.
Thank you, ma'am. Thank you so much. Dr. Saitava, ma'am, over to you.
Yeah. I would like to ask Dr. Shailesh Karvinde, sir. We all mostly know those monitoring sheets that are attached to our thalassemia patients' record keeping and all the textbook quoted recommendations and guidelines. I want sir to guide us the practical feasibility of this 3-monthly SGPT creatinine versus what is actually practically needed when, like ma'am said, most of us will put our patients on the preferred chelation Deficiency. So, like, can we just, patient-wise, can we modify this monitoring sheet, or should we stick to it like a mathematics timetable? I mean, what is the practical solution?
Okay, so I'll just tell you what our practice is those patients. See, I personally believe that whatever we investigate has to be in the context of the entire treatment being given to the patient and what kind of compliance the patient is having. I mean, there's no point in advising a huge set of investigations, including magnesium and so and all that, and the patient is not even taking chelation. Okay, so it has to be the level. If the patient is taking optimum chelation and you want to improve on it, there are various things which you can do. So what we do is we first definitely try to ensure that they are taking transfusions and adequate chelation properly. They focus on that. Once they are doing that, then we monitor their liver and renal function every 3 to 4 monthly. Sometimes at a longer interval if we feel that the patient is compliant and is otherwise doing very well. yearly evaluations, definitely we consider either the viral markers in children more than 10 years of age, looking at the cardiac evaluations, looking at the endocrine function. So age appropriate and treatment appropriate investigations is what I think we should be doing, because the list of investigations is very long, but otherwise it just becomes meaningless to do them when the basic treatment itself is lacking. So first focus on ensuring that the patient is getting appropriate chelation, and then you try to correct all those minor abnormalities which the patient may be having as a result of the treatment or the disease.
Yes. So I think practically everyone agrees. Seconds this thought, I think practically everybody has been doing this only. First focusing on the, not that you have we catch hold of the patient and then again first come with these investigations, we'll see and adjust. So yes, Dr. Parag has got another case scenario. I mean, we are little bit short of time, so going now in a bit short and little faster. Parag, you want to put up the next case scenario?
Yeah. I like to ask Dr. Lisa that we have a 9-year-old kid, a known case of transfusion-dependent thalassemia, almost requiring 200 ml per kg of blood per year. He is taking Deficiency 40 mg per kg per day, and he is compliant. He's taking it regularly and properly. Still, the serum ferritin level is 4,325. So I like to ask you, is there any other way to monitor the tissue ion deposition apart from serum ferritin level?
Yeah, so for tissue ion deposition, we do a T2 star MRI. T2 star MRI, the only practical problem with that is it is not available everywhere. There are hardly 1 or 2 configured licensed copy software we have in the city. And the one which is accepted by Thalassemia International Federation is only available in Mumbai. So for the T2 star MRI, we need a center which can be doing the MRI levels on the pancreas, pituitary, heart, and liver, all 4 parts. And if it is below the 3rd standard deviation, between -3 or -2, then we are very, very high alert regarding the chelation program, and we step up the chelation program based on the T2 star MRI. Usually this T2 star MRI is done about the 7 to 8 years of age. We do not start it as soon as we start the chelation of 1 or 2 years of it. The age of the patient is mostly taken as 7 to 8 years of age to start the T2 star MRI, and it has to be done annually.
So I like to ask you, Lisa, is there any association with the iron deposition in the different organ that you mentioned, in the pituitary, pancreas, liver, or in the heart? And is there any association of tissue iron overload with the serum ferritin level?
There is actually no proven data which correlates both of them with a serum ferritin level and statistical value with the T2 star MRI values. But since we know that serum ferritin is not a very diagnostic or a very confirmatory test for the iron overload, I will rather rely on a T2 star MRI, especially for the hepatic and the cardiac values, because sometimes when the cardiac overload comes magnificently high, we add up the second line of chelation in them, and sometimes we even go for an IV desferal for 21 days, 24 hours.
Okay. Okay. Dr. Sarita, over to you.
Yes. I would like to continue with Dr. Sandeep Bartakke sir on the same topic that is just started by Lisa. Like she said, you need to start on the second chelation drug in kids in some situation. Sir, can you guide us in what specific situation should we start thinking of about adding a second chelation?
Okay, so before that, let me just one sentence about ferritins. As Lisa said, there is no correlation between serum ferritin and liver and cardiac iron. However, what is important is to look at the trend. So we should not miss the trend. So that is important, whatever it is, ferritin or tissue iron. So trend is important. Now coming to adding the second or combination chelation, before that, so it is indicated in patients where you have ensured the compliance. Okay, some patients may be non-compliant for various reasons, and one of the common reason is adverse effects. So you address those first. Okay. So monotherapy, optimum monotherapy is first you should try. But some patients may not respond to it for whatever reasons and still have significant iron overload, especially tissue iron overload. There we can think of, we have two options. One, either go for alternative therapy. So means for some time you give one chelator followed by the other chelator. That is one option. Or you go for combination chelation. Now in combination chelation, what is well studied and approved is combination of desferrioxamine and deferriprone. So especially for the cardiac iron overload. So if you have that, so this is probably I would say standard of care, desferrioxamine plus deferriprone. Now, as Lisa said, especially those patients who are in like imminent cardiac failure, we would like to give them IV desferrioxamine 24 hours for maybe about 3 to 4 weeks, and then along with deferriprone, and they show significant improvement. Now coming to other combinations, so the most evidence is for this combination, but there are also many studies, although with small numbers, of combination of deferricirox plus deferriprone and deferricirox plus desferrioxamine. So, but for practical purposes, to us, because desferrioxamine is very difficult for our patients and requires IV subcutaneous or IV injections over significant number of time and the cost involved in pump. So for us, deferricirox plus deferriprone sounds more practical. And what has been shown is that it works. It works. It reduces the iron overload in tissue as well, liver, cardiac, and also ferritin. Again, those studies, all the studies have showed that it works in patients who are compliant, because in combination your compliance problem is again increased, because you now have to take 2 tablets with maybe more side effects. So combination therapy is required sometimes, and for practically we can give deferricirox plus deferriprone, and that we have also given in a few patients, and it works.
Bhattacke sir, curiosity and as a future trends, some in the study regarding iron metabolism. So what can we expect, the practical outcomes from that depth of study regarding the iron metabolism, and how it can be practically executed in our patients regarding chelation?
You're sorry, I couldn't hear you properly. You're asking about newer treatments for iron metabolism?
Yes, sir. Iron metabolism, at any levels it can be addressed actually practically. Yes, sir.
Okay, so we know in small molecules which have been targeted against this iron metabolism. For example, hepcidin analogs or mini hepcidins, which will reduce the iron iron absorption and improve. Not only improves the iron overload, the iron overload and ineffective erythropoiesis. These are the two fundamental pathophysiological processes in thalassemia, and they have bidirectional effect on each other. So if you reduce the iron absorption, it not only reduces iron overload, it also improves hemoglobin, it also improves your RBC survival. Okay, so ferroportin inhibitors, hepcidin analogs, TMPRSS6 inhibitors, all have been under various phases of clinical trials. None has been approved yet, but next 10 years it will be available.
Yeah, so there is a hope. Maybe we can do something other than chelation for them. Dr. Parag, shall we go to the definitive treatment discussion? Yes.
Yes, ma'am. So, Bhavna ma'am, I want to ask you, our original patient, Ashrik, their parents are very curious to go for a definitive treatment for their son. So, can you just tell us about the definitive treatment, how to prepare the child for a definitive treatment, and what is the preferred age for the that modality?
I would like to stress that it is very important to introduce this idea of definitive treatment quite early in the diagnosis. There is a reason for that, because the best outcomes of transplant has been when you have transplanted the child early, at least less than 7 years, and best is between 3 and 5 years. And as you know, there is the Uterally or also known as Pissarro's criteria, where if you have a hepatomegaly which is less than 2 centimeters and the child is regularly chelated, and there is a very minimal or no portal fibrosis. These are the children whom you can have outcomes more than 90%. So it is very good to initiate the discussion of a definitive therapy, because the parents will also need to mobilize so many other things, including finances. As far as the preparation goes, as it goes without saying, transfuse well, so there is very less extramedullary hematopoiesis. Chelate properly so that there is very minimal tissue iron deposition. And if the transplant is imminent in the last 6 months, see that you give evaluated blood products, confirm the CMV status of the child, and if he is CMV negative, then see that you give CMV negative blood. This is very important. Finish off the immunizations of the child. So these are all simple preparations just before transplant.
So, ma'am, who can be act as a donor for these patients for definitive treatment?
So, as I would like to say that I am not a transplanter, so I'm not regularly doing transplant. But yes, some amount of counseling and knowledge. What I tell them that the best donor would be a matched sibling donor. So that is still the best, and that is the standard of care. The next would be a matched transplant, but from an unrelated donor. So that is when you get fully matched donor bone marrow from registries. So in India, we have the registry which is known as TAPRI, and then you can get a matched donor from there. The next cares would be to get unrelated, unmatched graft. So that is still experimental. So especially the haploidentical, that is a match transplant from either of the parents, because either of the parents are going to be only half matched with the child. So these are all still experimental therapy, and you need to go ahead only with lots of discussion with the parents, discussion about the outcomes, about the long-term outcomes, about the side effects, even about the mortality in that case, and of course the cost. As you go through this line, the cost keeps on rising up because the support required is very high in these kinds of transplants. And we know that thalassemia is a chronic benign condition. So we have already seen that with the proper management, we can have very good, excellent outcomes. So we need to weigh the scale. That will depend on each and every family, the treating physician, and the transplant team. So with a lot of proper discussion, we need to take this kind of decision.
Thank you so much, ma'am. Dr. Sarita, can you take ahead?
Yes. I would like to ask Dr. Shailesh Karvinde, sir. Sir, what's been the success outcomes of, let's say, matched sibling donor for thalassemia transplants? Like, let's say, what's the Indian scenario for the success rates? Because the first time when we tell them, the question that they pose us is, what is the success rate when we'll do all this? What happens and what are the outcomes, and is it actually transfusion free after that?
Okay, so I think Vibha mentioned about the Pissarro risk factors, the risk categories, and that is something very important in deciding the outcome. Patients who are well chelated, are transplanted early from a matched sibling donor can do very well in Indian scenarios, definitely anywhere. Those who come late, who are poorly chelated, who have a lot of iron overload, will have more complications, will have risk of graft rejection as well as organ toxicity, EOD, and so on. So I think the outcome will depend on what is the status of the patient at the time of transplant. But overall, with newer techniques, newer conditioning regimens, even for those with poor outcomes in the past, especially the Pissarro class 3, where almost 30% of the patients used to reject or fail the transplants. Now, for them also with newer therapies, pre-transplant as well as preconditioning as well as conditioning changes, I think the outcome is going to be is improving. So for a child with, let's say, Pissarro class 1, young child less than 5 years, good chelation, no hepatomegaly, we can expect a 90% chance, 90% plus chance of a long-term survival, transfusion-free survival.
Okay. So I think in ideal scenarios, when we are counseling them, when we say this 90% in ideal scenarios chances, I think that motivates them to actually further fight for the definitive treatment. Many times they will ask us otherwise the other way. They'll hear from someone and then come with mixed questions. So Parag, you want to address the other controversy with
about the management? Yeah, I will like to ask Dr. Lisa, that we have heard a lot about the splenectomy and the patients having an excess transfusion requirement in the thalassemia. So I want to ask you, what is the role of splenectomy in the management of thalassemia major?
Nowadays, in very, very recent years, we do not opt splenectomy as a standard of care procedure for thalassemia because of the risk of sepsis and also the risk of portal hypertension in splenectomized patient and the vein thrombosis and everything else. It is very, very rare scenario that we will opt for an splenectomy for any child with hypersplenism. But yeah, there are certain indications which we do not leave, doesn't give any option. But still, when there is a massive splenomegaly, we rather cover with a very aggressive transfusion regimen rather than opting for a splenectomy. But certain times when even if we give regular transfusion, very aggressive transfusion, shorter duration, 20 ml per kg, but then also there is increased blood requirement and there is no adequate control over a proper chelation and everything, and there is hypersplenism which is leading to cytopenias and causing clinical problems. And if there is a symptomatic splenomegaly, I think that will be the number one reason from my side. If there is a symptomatic massive splenomegaly causing pain in the right upper quadrant, in that case is probably the option of splenectomy might be, given a chance for an exploration.
So I like to ask you, Lisa, if in certain circumstances, if the splenectomy is needed, so what will be the age where you will recommend to go ahead for a splenectomy, or I can say until what age you will try to avoid the splenectomy in this patient?
If it is absolutely necessary, then probably above the age of 5 years. Less than 5 years, we will not opt for splenectomy whatsoever the clinical scenario might be.
Is there any special preparations required for a splenectomy in this patient?
Yes, the special preparation will be the vaccination priorly to opting for splenectomy of the all capsulated organisms. And after that, probably starting the child on penicillin and aspirin, a very low dose of it, post splenectomized patient. And we will have to be very careful once the spleen is removed, because the spleen is the main organ where the iron overload was going to take place. Now all this iron will be diverted to hepatic, cardiac tissues, and in that cases the complications will increase again along with the sepsis.
So now these parents, when we talk about the splenectomy, they ask about what will happen to the transfusions requirement after splenectomy. So how will you like to address to them?
So initially the transfusion requirement will be lower compared to what aggressive transfusion we have been giving because of massive splenomegaly, and then slowly over a period of time probably it will come into a regular transfusion cycle.
Okay, thank you, Lisa. Sarita ma'am, can you take over?
Yeah. So I would like to ask Sandeep Bhattakke sir, I mean, anything in this pipeline regarding any new treatment options for the thalassemia syndromes? I mean, which we can accept to actually materialize soon, maybe like we considered iron metabolism. I mean, we can address that iron metabolism and come up with something. Anything else we need to, watch for if something is promising there? Hello.
Hello, as we know,
Yes,
it has been a very exciting times for treatment of thalassemia and many other hematological disorders in particularly in the last decade. So I would say the non-pharmacological approach for curative option, apart from of course transplant, is gene therapy. And actually, there have been phase 3 trials of gene therapy using lentivirus. So there are two approaches here. So one is to insert functional beta gene, okay, through integrate it into lentivirus and then integrate it into the stem cells collected from the patient, CD34 cells, and after that you do conditioning with busulfan and give back those transduced stem cells back to the patients, which will produce the normal hemoglobin A. So that is one approach, and the second approach is editing. Gene editing by different nucleases. One of the popular one being CRISPR. So what they do is either you correct the mutational defect or you induce or promote gamma chain synthesis, and similarly you transduce these stem cells with these genetically modified lentiviruses, and then practically clinical trials have shown that majority, almost 80 to 90, especially the recent version of the gene therapy has shown almost 90% of the patients have had very good response and off transfusion. Problem is it was held in 2021 because there was a couple of events of acute myeloid leukemia or MDS in sickle cell anemia. So similar to thalassemia, in sickle cell also this gene therapy was so there, that's the reason it was on hold. However, after a lot of investigation, it was found that it was not related to the insertional mutagenesis or oncogenesis. Hence, again, I think it has been given go ahead. So I think it's a reality, and maybe hopefully in next 5 years, we will also be able to use it. So apart from gene therapy, there are a lot of pharmacological agents which can help in thalassemia. For example, and they target, majority of them target either ineffective erythropoiesis or iron overload or HbF induction. So different like erythropoiesis stimulating agents or JAK2 inhibitors like ruxolitinib, or those targeting the erythroid maturation agents, okay, or even the HbF inducers, where we know that hydroxyurea and thalidomide that we are aware of. Again, we should know that hydroxyurea works especially in patients who have XMNL polymorphism. So they work in particular subclasses of thalassemia patients, or thalidomide works, with certain polymorphisms. But again, the data is very small at the moment, and very small trials from India and China have shown some benefit of thalidomide. However, we also have to bear in mind the risks involved and the side effects involved. So I would not say it is standard of care as of now, but we should wait for more data. What is approved in adults is erythroid maturation agents called luspatercept. Okay, so that has been approved by FDA in adults for thalassemia. So what it does is that it improves the ineffective erythropoiesis, and you have patients require lesser and lesser transfusion. So a lot of exciting times. So let's see which agents make it to the bedside.
Yes. So, but there's a lot of hope still in the pipeline also. Maybe it might just change the whole story of what we have gone through so far. Yes. Thank you so much, Sandeep Bhartakke, sir. Parag, should we hurry up over the antenatal diagnosis? Yes.
Yes, sir. Sir, Shailesh sir, I want to ask you about the antenatal diagnosis. In our patients, they want to take a second child. So how can they avoid the thalassemia in the second child?
The first thing to do is to get the genetic study of the affected child, because we need to know what the mutation is exactly. Then we need to screen for that mutation in both the parents, and then go for a prenatal diagnosis. which can be either a chorion villus sampling or amniocentesis, which are the common techniques which are used currently, and identify the defect there.
So, sir, yeah. So now this parent want to know what is the chance that the sibling will be matched with the index case. What is the
So
percentage?
that is a tricky situation.
Okay, then what is the percentage that? Yeah.
No, so what we tell them whenever you're going to do a prenatal diagnosis, do it if you want a healthy child. Don't expect a transplant donor to be available. Okay, that is what we generally advise, because we've seen or we've heard of cases where because the child did not match, the parents rejected the child. So the main thing important is the child who is going to be born should have an independent existence, and it is because you want another child, you can go ahead and do it. Don't have another child just because you want a donor for the first child.
I think
that's something.
Is there any
science has gone ahead, and science is not agreeing to that. That is, science is now offering PGD,
No, that's fine. That's different. That's different. No, that is so. Pre-implantation genetic diagnosis is feasible. It is done. I'm coming to that. But without that, I mean, see,
I totally
without that,
I don't think we are allowed to do, if you are doing prenatal diagnosis, you do screen for thalassemia, but I don't think we are allowed to do HLA typing at that point. That is not.
And then it will not make a difference.
HLA typing at the time of chorion villus sampling is not allowed.
No,
I don't think that is not.
That is not done.
No, I'm not talking of that. I'm talking of having a child being born and then found not to be a donor can be a cause for some discord. So one approach which people are advocating is to do a pre-GD, as Vibha is saying.
Yes.
I'm not too much in favor of that, but I think that's
not ethically or legally still allowed in our country. I think people go to Hong Kong or other countries to do that.
No, but I think there's somebody in Bombay who's doing it.
Bombay, just look there.
Yeah, it's being done in India.
There is no legal issue in PGD.
I'm talking about HLA matching.
HLA matching, there is no issue.
Yes, it is
there
being
is
done.
No legal issue. It is being done. There is no legal issue, but then as Shailesh is very rightly pointing out, from the family point of view, like you are recognizing that child not just as a child, doesn't have his identity of his own. He is like a donor for the index.
So
there is a very famous novel on that. I don't know whether there's a very, very good movie on this issue. I think we can just go on discussing. Very famous movie and a novel is there. I'm forgetting the name.
So in the antenatal diagnosis, we can diagnose that baby is not suffering from thalassemia, but we will not go ahead with the HLA matching of that fetus for the index case.
No,
so
that will not help. And that nobody is going to allow you to abort just because he is not naturally matched. So that is absolutely no issue.
Okay, sir. So, ma'am, I would like to ask you, how can we implement the preventive measures for this thalassemia disease at the population level or at the broad level?
Yes. So basically, thalassemia, sickle cell, all hemoglobinopathies are the commonest single gene disorders, and they are inherited autosomal recessively. So they have a very clear-cut sort of genetic thing. So both the parents need to be carriers, and there is a 25% chance in each pregnancy that the child will be a major. Okay. So what you can do is the prevention has a 4-pronged aspect. First is the education, second is screening, genetic counseling, and antenatal diagnosis. So these are absolutely the 4-pronged methods to prevent births of thalassemia major. Education has many levels, right from a CME like this for all doctors, obstetricians, pediatricians, general practitioners, then to your young adults. So you can have it in curriculums in colleges, high schools, and then for general mass, that can be on social media, on newspapers, TVs. So this kind of education is very important. Next would be screening. So you could go screening on, the ideal screening would be for everybody, but that is not feasible. The most feasible level of screening, as I said, is in the antenatal clinics. So you screen each and every mother, other parts of screening which I think is important. So there are some known communities, for example, Punjabi, Sindhis. So you can screen all the young adults there. You know? So that can be done on a social platforms. After having screening, identifying carriers, and then doing a genetic counseling then once you've identified carriers. So, and once you've identified a couple, then offering antenatal diagnosis. So this would be a way to go for zero thalassemia birth rate. So as our Pune Thalassemia Society has, you know, it has been declaring that we want a zero thalassemia Pune district by 2025. So let's go for that. It's not a distant thing. So many countries have achieved it. I think we should be really, really aggressive and go for that.
Thank you so much, ma'am. Dr. Sarita, ma'am, over to you.
Yes. So now we have discussed, I think, most of the aspects that we all wanted to hear from our eminent panelists. Lisa, I want to just shed light in a small, short time about the existing government policies for the thalassemia patients and some, I mean, your expectations as a clinician working in that field. What do you want more from the government? So maybe we as a team, we all can, you know, hope for some best support in the government sector.
So the scenario for thalassemia from the government point of view is exactly opposite, where we are, you know, we have a habit just to curse the government that they're not doing any work. But for government scenario for thalassemia, they are doing fantastic work. First of all, Hplc test in every PHC or any district hospital is done free of cost. And the chelation drugs for whatever require, maybe the Calfer, even with the Desirox, it is given free of cost to all the patients once they go to the hospital. And another thing is that the government has a state blood transfusion committee and national blood transfusion committee. So whoever with the diagnosis of thalassemia or any anemia which requires regular transfusion, they are given, they have to send this reports and a form with a letter from the clinician to the office, which is currently in Santa Cruz, Mumbai, for Maharashtra. And one SBTC ID, especially for the child, will be made. And with this card, government will give free of cost blood, how many times he requires during the lifetime to this patient. And the blood bank cannot deny this right. And
this meeting is being recorded.
Yeah, and another thing which is fantastic work done by government, which is Whole India project. So there are 5 centers identified all over the India, and transplant for thalassemia and aplastic anemia also included in this will be done free of cost. There are certain guidelines which has to be followed for this age, and it has to be a class 1 Pesaro class. And currently Mumbai KDA, Dhirubhai Ambani Hospital has been granted a Whole India project. And there is a disability card provision done for every child after the age of 10 years. Under this disability card, every child will get a free admission in whatever school or college he wants, and 10 to 15 minutes extra in the 10th standard and 12th standard exams. With this disability card, they have a 10% quota for every college for higher education, and 10% quota for private and government jobs. They are given the leave for 1 to 2 days extra every month for their transfusion. That is a paid leave from any private sector job or the government job, which has to be given to them. And moreover, there is a pension scheme which is currently started by Haryana government. They get around 2,500 rupees per month every thalassemic warrior and stage 2, stage 3 cancer and hemophilia patient. And very soon, Pune municipality is also going to start this pension. Hopefully, it starts soon. And if one of our centers in Pune can get a Whole India project, and we can start free of cost transplant for thalassemia and aplastic anemia, nothing like it.
Thank you so much, Lisa, for building up our hopes in our own government. Yeah, we should. I think the parents should be aware of these all facilities that are there for their children. And many of them might not even know that they have got so much than the right access also. I mean, especially the kids who are coming from periphery will just keep on focusing on getting
because the air travel, bus travel, and train travel is free for thalassemia children. And nobody is aware, so nobody is doing, using the services.
Very true.
I
Yes.
think what is needed, what is, of course, that this is fantastic what government is doing, but what is really needed and which is like high time now, that we need a national thalassemia prevention program. Countries
Yes,
like Cyprus have almost eliminated thalassemia. Now
Yeah,
this is
zero
high time.
thalassemia.
Yeah,
You know,
so
I
high
think
time
we
that
should
we
be
need an
preventive
obstetric.
aspects should be really given a big boost.
yeah. And especially in times like this, when we have thalassemia on a rise, when Thalassemia International Federation has published a paper that thalassemia is on rise again.
Correct.
Yeah. So that was great. I mean, I can just listen to all of you for hours and hours together. So maybe Parag, anything more you have in mind that we should not lose this opportunity of,
So
extracting
I think
information
we
that
have
is.
tried to cover whatever questions possible. Right now, I'm not able to think of anything. I just want to ask Lisa, means like if just now we discussed if the patient don't have genetic test and if there is no HPLC report suggestive of major, maybe because of transfusion. So how can they approach for this getting this free card from the government setup?
So in that cases, they will ask for HPLC for sure. But in that cases, when we can make a letter of exception from a clinician, because there are a lot of people who are on regular transfusion and still didn't have the cards and everything. Then we had just wrote a letter with a letterhead, and then the provision was given with a confirmation from our side.
We can do a parents HPLC. We can give
Yes,
circumstantial
Yeah,
evidence.
so does
That's
the
your clinical
correct,
and a
correct.
circumstantial.
So this parents
yeah.
HPLC, okay,
They will
okay. So
accept a
will they
letter
accept
from
But
a
it's not
parents
a
HPLC report?
definitive diagnosis,
Yes.
but it's a circumstantial evidence with the clinical presentation and the parents being minors.
Yeah, because it is not
Okay.
just for thalassemia, because the pyruvate kinase deficiency, aplastic anemias, people going for bone marrow transplants, all of them are included in the state blood transfusion committee. So just a letter from the clinician that he is requiring 21 days transfusion, that is sufficient. Only a confirmatory call from the SPTC will come to you on the number given.
Even the Mahatma Jyotiba Phule scheme is covering very nicely.
Yes,
the
yes,
genetic tests, annual tests, 3-monthly tests, and chelation drugs free. So
Chelation also.
Yeah. So mostly all the daycare centers either have the Mahatma Phule Yojana or the center which is giving free of cost chelation, just to minimize the economic burden of the parents and the children involved with thalassemia.
Yes.
Okay, you want to add something, Dr. Sarita ma'am?
I just want to add that thank you to the great moderators, Sarita and Parag, excellent moderation. And thank you to IAP Pune for giving us this platform and let us, vent out all our emotions about thalassemia. I'm sure all of us are very emotional when it comes to thalassemia and managing them. Thank you very much.
Yeah.
So thank you for the opportunity, IAP Pune. Thank you, Shailesh Karvinde sir, Sandeep Bartakke sir, Vibha ma'am, I mean, Lisa. We can keep on talking on all this, sharing experiences also. Yeah, stay in touch, everyone. Parag Gaikwad sir, shall we close it?
Yes, I think we can close it.
Yes, yeah, it was nice seeing you all.
Yeah.
Yeah.
Thank you.
Thank you so much, everyone.
Thank you, everybody.
Yeah, bye.
Bye.
I'm not a very keen person on thalassemia. Yes.